Testing, testing. So this is just a draft practice run. Really trying to make sure this is like around 40 minutes. Yeah, if there's some minor typos and whatnot, I'm gonna let it go. But the goal is just to make sure that it sounds good. Okay, here we go. Hi, my name is Yev. Thank you so much for inviting me to give this talk. And I'll be giving this talk on transfusion practices as it's relevant for anesthesiology. Here are my disclosures. I don't have any financial disclosures for this talk. All images are stock or from publicly available databases. Please give your candid feedback at the end. Take some notes so that I can make this presentation better for you all next year. Save your questions till the end when possible, but if it's urgent, I can answer some during the talk. And slides will contain a little bit more extra text because these will be provided after lecture for your own independent review. Our objectives are to cover the ABO blood groups, the basics of pre-transfusion testing, and describe the components and indications, and understand the massive transfusion protocol. So raise your hand if you heard of any of these tests before. Okay, well, keep it raised if you want to go through and explain them. And it's fine, I'm not going to pick on any of you all. We're going to walk through these tests and see how are they useful for you all. 3 blood groups. They are A, B, and O. O doesn't really have any antigens, so plasma has A and B. There's also A blood group, which has red cells that contain the A antigen. Plasma has B, and the B. And I don't want to read the slide for you here, but the takeaway point here is that these antibodies are naturally occurring. They're IgM. They're clinically significant. They can cause intravascular hemolysis, bind complement, result in shock and DIC. To explain some of the concepts in transfusion medicine, I'll have to talk about pathophysiology. And physiology, so please humor me, because yes, the blood group antigens, there's also the minor blood groups. They are markers on the external surface. There's about 400 of them, and more are discovered all the time. The examples are listed here for you on the slide. They are minor blood group antigens, so these antibodies are developed after exposure. They're usually IgG. They typically don't bind complement, and they cause extravascular hemolysis. There's several relevant blood bank tests for the OR that you should be familiar with, and how long it takes to resolve the result on our end. And type and screen is pretty quick. It could take 30 minutes up to an hour. If the patient has antibodies, it can take longer. But if these antibodies are known and we're ready for that patient with blood products, it will take, again, shorter. The screen is valid for 3 days, and that's just an important part to know. The screen is either positive or negative. Then there's the antibody identification. This can take at least 2 hours, sometimes longer. So if you are aware that your patient has a bunch of antibodies, please order type and screen earlier rather than later. The type and screen extend, these are great when the patient fits into this criteria, because this is great for patient care, for OR. Type and screen can be done 30 days before surgery, but the criteria is that there's no history of pregnancy or transfusion in the last 3 months, meaning that there's no possible risk of exposure to blood, and that there's no antibody formation. If the antibody screen is positive, the test is not valid. And type and cross-match, we do not do that here. So the type of blood products, there's only 4 blood products. They're listed here for you on the slide. The goal of red cells is just to bring oxygen carrying capacity to the tissues. And platelets, plasma, and cryo, they are really there to support the endothelium for the red cells to deliver the oxygen capacity to the tissues. So what should the transfusion thresholds be for red cells? Let's summarize this. This field is very complex, and there's a lot of studies out there, but the guidelines currently recommend a hemoglobin of 7 as the trigger for transfusion. The hemoglobin levels affect symptoms. As you all are familiar, that some patients can be they can live around from 9 to 11, and they have little or no dysfunction because for them that is normal. But when they start dropping below hemoglobin of 7, they start developing exertional dyspnea, weakness, and they are at risk of cardiac failure when hemoglobin drops too low, from 2 to 2.5. So that number 7, the hemoglobin of 7, where did it originate? The red cell transfusion thresholds were evaluated on 30-day mortality versus mortality during hospitalization. All non-bleeding critically ill adults were included in this study, and this was done in 1999 in Canada. There was almost 900 patients here, and they compared the restrictive threshold of hemoglobin 7 to the liberal transfusion threshold of hemoglobin of 10. And you could see that the 30-day mortality between the two categories was the same, but mortality during hospitalization was less in the restrictive transfusion threshold, and it's shown by the on the right. You can see restrictive transfusion threshold has better outcomes. Liberal transfusion strategy has worse outcomes. So restrictive transfusions actually did better. The story continues because in 2013, transfusion strategies for upper GI bleeding was published. And this study had 900 patients, and they compared a hemoglobin of 7 versus a hemoglobin of 9, and this was stratified by cirrhosis. You could see that the probability of survival was significantly higher in the restrictive strategy group, indicated by the green arrow at the top. When they did a subgroup analysis to stratify it by patients with cirrhosis, Child-Pugh, or bleeding from varices or peptic ulcer, they were not able to find significance, but things still trended better in the restrictive strategy, did better, but they were not significant. But overall, the patients with restrictive strategy did better, so hemoglobin of 7. There's been many more clinical trials since then comparing the lower threshold to the upper threshold, and they have all found over and over again that there's improved restrictive outcomes at restrictive threshold, and there are non-inferior outcomes, or they're non-inferior. So I'm gonna just pause here for a quick second, and then we're gonna move on to platelets. So platelets, what is their function? Their function is kind of like if there's a flood and you put sandbags in the ditch, they prevent the flood from going places. They are this little sandbags for the endothelium, and they act as primary hemostatic plug. They are also a source for fibrin formation, and the deficiencies could be from many other causes like consumption, destruction, production like bone marrow disorders, or sequestration, spleen, and like liver disease. Platelets are these, the span in vivo is about 10 days, but post-transfusion is 4 to 6 days. In general, in an ideal patient, a platelet should raise a count from 30 to 60,000. And here is also a picture of what the platelets look at the blood bank. When you guys rotate through the blood bank, you will get to see them. Platelets are very, very finicky and very temperamental, and also need to be treated very gently. They are only, after they're collected, they are only able to have a shelf life of 5 days, and we get them already at like day 2 after all the testing of them are done. So they move very quickly. They need to be stored at room temperature with gentle agitation because it allows oxygen to permeate the cells and provide the platelets with nutrition. They're at higher risk of bacterial contamination because they're kept at room temperature, and we only carry 30 to 40 for the entire hospital. And that's also important to be aware, but that's okay. This is pretty normal. They need to. Please do not store them in the fridge. Please do not put also cryo in the fridge, because if the platelets go in the fridge, they do not become. We will have to waste them, and we understand that we really hate wasting platelets because patients need these units. Cold store platelets, they're approved for clinical use. They have a longer shelf half-life. They have a lower risk of bacterial contamination, but we do not use them at UW or Harborview Medical Center. And I'm happy to discuss this after the talk of like the pros and cons of cold store platelets, but in just a very quick snippet, they're very great for trauma care. Trauma care where there is like poor logistical support. So like on the front lines of like a war, for instance, they're great for that. But for day-to-day use, they're actually not that great. And we can talk about that later. Platelet transfusion thresholds, in the context of an MTP, the goal is to keep platelets at 50,000. There's because you're trying to prevent bleeding. In cases of prophylaxis, when the patient is stable and not bleeding, you can give them platelets to prevent spontaneous bleeding, and also platelets before their procedure prevention. These guidelines are recent. They came out just last year, and they're great. This was a international study. It was a really helpful paper because the literature needed to be updated, and this was published also by authors from here. So this is our work, and it's great. It's great. So the new update here is that platelet transfusions should be administered when for lumbar puncture when platelets are less than 20,000. The other threshold for you is a little bit out of the scope for this talk, but we can touch upon them when you have questions. Other important things that are relevant to anesthesia and the OR is that in patients with central venous catheter placement that are amendable to compression, the platelet count should be greater than 10. In adults undergoing interventional radiology procedures, the platelet counts should be greater than 20 if it's a low-risk procedure and greater than 50 if it's a high-risk procedure. In general surgery cases, platelet transfusion should be higher than 50,000. Platelet count should be higher than 50,000, and if the patient is non-thrombocytopenic and they're undergoing cardiovascular surgery, if there's no major hemorrhage, including those receiving ECMO, there's no need to transfuse platelets. If their platelet is, if they're not bleeding and they're non-thrombocytopenic. In adults with either neurotrauma or neurosurgery patients, or when neurosurgery is going to do a procedure on them, the platelet count should be greater than 100,000. This is just a screenshot from our transfusion guidelines at UWMC. Again, take a look at them when you get a chance. They have really nice lists. Another thing for you all that might be helpful is that you need platelet counts in general of greater than 80,000 for epidural or spinal anesthesia. I'm going to take a pause here and just stop here for a moment and say that, hey, we have these numbers, and that's great to know. But patients don't read the textbook. Patients' diseases don't read the textbook, and our patients are complex. You may not be able to hit some of these numbers. So if you're close, for example, if you have a platelet count of 48 before a major surgery or lumbar puncture, or there's bleeding, 48 is just good as 50. And so just I want you to keep that in mind, because we have instances where a patient's procedure is delayed because the clinical team feels unsafe with a platelet count of 48, or sorry, of 49,000 or 48,000. And I get it, we're not at the bedside, so we can't appreciate the whole story. But if it's clinically reasonable, sometimes chasing that specific number does a disservice to the patient, delays the procedure. We're happy to give you guys whatever platelets you need, but just keep that in mind. Like 48 is just the same as 50, 49 is just the same as 50. So let's talk about the next topic, which is plasma. Plasma is, it contains all the coagulation factors. It's good for replacing coagulation factors. It comes in these large yellow bags, as you can see right there. It's kept frozen. We thaw it in about 15 minutes, and after thawing, it's available for 5 days. The INR of plasma is roughly 1 to 1.5, and this is kind of important to keep at the back of your mind. The general clinical assumption, and this can be overly simplistic at times, is that, if there's elevated INR, elevated PT, it will increase the risk of bleeding. Let's transfuse FFPE. Correcting it will reduce bleeding. And so, does abnormal PT INR correlate with risk of bleeding procedure? And the answer to that and this was already known in 2005, that there's no evidence that abnormal results predict bleeding. And these are, cases, these are complex patients, like transjugular liver biopsy, liver laparoscopy biopsy, kidney biopsies, and it's a large study of a systematic review, including 1 randomized controlled trial and 26 observational trials. So let's look at the summary of evidence for plasma therapy. Most patients with mild to moderate coagulopathy do not have adverse bleeding post-procedure. Patients with an I of less than 2 probably do not need prophylactic therapy, and most certainly not for INR of 1.7. So if the patient has an INR 1.7, plasma will not correct it, and I will explain that in the next slide. And then there's a retrospective audit of plasma transfusions showing that patients with mild coagulopathy, the INR did not correlate with estimated red cell loss. So why can't plasma lower an INR of 1.7 to 1? Because an average 80 kilogram adult has a blood volume of 5-6 liters. The plasma volume is 3.1 liters. So each unit of plasma it's about 250, but each unit INR has an INR of 1.2 to 1.7. So you could see that it's impossible to reach an INR of 1 with plasma alone. And again, donated plasma is typically between 1.1 to 1.5. So you're really, like, even if you were to replace the entire plasma with plasma of a patient with plasma off the shelf, it would still be 1.5. So just wanted to leave that there. What is cryoprecipitate? It's the precipitate of cold thawed plasma. So it contains fibrinogen, factor 8, factor 13, and it takes 15 to 20 minutes to thaw. If you needed to order it and you need it immediately, please order it ASAP. The contents are, they contain factor 1 at 150 milligrams, factor 8 at 80, and 1 milligram factor at 80 to 120, and factor 13 at that level. But factor 13 is not that important for this. It's really about factor 1 and factor 8. We give you guys these units in a pre-pooled units which contain 75 mils. For us to know, the storage is minus 20 1 year and 22 Celsius at room temperature. It lasts for 4 hours. And in a 70 kilogram of patients, one pool raises fibrinogen by 40 milligrams per deciliter. The cryoprecipitate recommendations is to replace fibrinogen in clinical situations when it's rapidly being consumed, and this includes the bleeding patients like MTP or peripartum hemorrhage and DIC. Let's talk about our massive transfusion protocol next. So in massive transfusion, the goal is to provide blood products in the patient with active bleeding, who has circulatory failure. MTP activation, please call the blood bank and order 4 units of red cells and 4 units of plasma. These units will be sent as soon as they are ready to be issued, and we have a 1-to-1 ratio here of 4 red cells and to 4 plasma. Also, please order the emergency hemorrhage panel because it allows you to, it's done very quickly. It's a high priority test for us. It allows us to monitor the hematocrit, red cells, platelets, fibrinogen, cryo, and PT and, sorry, I misspoke. The emergency hemorrhage panel contains hematocrit, platelets, fibrinogen, and has also PT. This will let you know whether you need to give red cells, platelets, or cryo. Also, if you need to, please consider a TEG and provide antifibrinolytics. The simplistic coagulation cascade is that depletion of fibrin will increase PT and INR. In regards to postpartum hemorrhage, there has been a study that looked at coagulopathy in almost 13,000 deliveries from about 4 years at Duke Medical Center. The most common causes of postpartum hemorrhage, and for coagulopathy specifically, are the result of anatomy that developed from anatomical bleeds that failed uterotonics or sutures. On this paper, it's actually quite hard to predict what patients develop coagulopathy. But there was a study that was published by Sunny Zeek and Chad Bitt in 2007 that looked at fibrinogen levels in severity of postpartum hemorrhage. In general, non-pregnant patients have a fibrinogen of 150 to 300. Pregnant patients have 250 to 500. In pregnant patients, it's indicated to maintain, in postpartum hemorrhage, it's indicated to maintain fibrinogen of greater than 200 in severe PBH. And a fibrinogen level of 2 grams per liter or 200 micrograms per deciliter had 100% predictive value for severe PPH, and no woman with fibrinogen of greater than 400 developed severe PPH. And conventional coagulation tests were not useful as early predictors, so fibrinogen was key discriminating value here. It's also important to note that we are asking you all to maintain fibrinogen of greater than 200 because it's below that level where's the high risk of 100% predictive positive value for PBH. At 400 levels, that just means that the fibrinogen is just not being consumed, and these patients do fine. But so try to transfuse cryoprecipitate above 200. How do we minimize risk of blood transfusion? There's several ways to do this. Before surgery, you could do anemia identification and treatment, give iron, either oral or intravenous, or EPO. During surgery, surgical technique is important. Pharmacologic intervention is also helpful, like antifibrinolytics. And if there's an OBB, bleed, you could use early TXA. Trauma, you could use, you could look at the SHOT trial. There's also blood conservation strategies like cell saver and acute normal volemic hemodilution. After surgery, limiting phlebotomy. Again, just a quick summary for MTP activation. It's important that UW Montlake MTP is 4 red cells, 4 plasma, 1 platelet, and we have to order the platelet yourself, and you have to let us know about the platelet. And then for Harborview Medical Center, the MTP is 6 units of reds, 6 of plasma, and 1 platelet. There's a reason for this, because usually the patient population at Montlake is more surgical GI OB, so it's single system affected. It's really more like a focused insult on the endothelium. At Harborview Medical Center, there is more of a commonly multiple system affected, this generalized microvascular insult to the endothelium. And here's a flowchart on the left side that says we initially will send you 1 red cells in the tube, then it will send 2 red cells and 4 plasma in the fridge, and for 1 platelet and 1 cryo, it's upon request. And we can get you the first 2 red cells in 5 to 7 minutes. The end goals of stabilization is resolution of symptomatic anemia, INR of less than 2, fibrinogen greater than 150, platelet count of more than 50, and the core temperature of greater than 35 Celsius. Please give back the fridge. If it's been 1 hour since component transfusion, please give back the fridge, because we have to take these products. Ask us questions. Some of you will, I think, either do electives with us or rotate with us in the future for like a tour. And here is our amazing team.